All right, I'll now run my presentation again as suggested by David. Um, Thanks, Yelu and David for comments. I'll try to run this presentation once more, just to rehearse, and then perhaps hear back from you before I record it. Thanks very much for the comments you had. I've tried to implement them. Now I begin. Dear audience, dear organizer in Denver, thank you very much for inviting me to give this talk about ethical aspects around mass screening for celiac disease. I'm very happy to attend the second annual celiac disease screening symposium in Denver, even if I'm not there in person. My name is Jonas F. Ludvigsson from Sweden. Would have been lovely to be with you in Denver. Would have been lovely to be exactly 1 mile above sea level as Denver is situated. I've also heard about your airport, which I would have loved to see. And being a sports buff, I love sports. I know you have perhaps more elite teams than any other city in the US. So a short overview of my talk. I will give a background on celiac disease. I will talk about what is mass screening. I'll talk about the ethical frameworks around celiac disease screening, about the benefits and harms of celiac disease screening, and case finding versus mass screening. But I'll also give you a short background on myself. I'm from Sweden, which has one of the highest prevalences of celiac disease in the world. I'm an epidemiologist. I like numbers. I'm a pediatrician, and I work to a large extent in the wards also with cancer, diabetes, severe infections, neurological disorders, but also a lot in the emergency room. I'm also the scientific chair of the SCRESCO study, one of the largest randomized colorectal cancer screening studies in the world. And I also authored this paper in the UEG journal, now cited almost 200 times. One of the first, I would say, extensive reviews about screening for celiac disease. So what is celiac disease? We need to know that because it's the foundation for screening. Well, it's an autoimmune enteropathy triggered by gluten that affects around 1% of the Western population. Symptoms may vary, and that's important because it means the disease may be hard to find. We have GI complaints, we have anemia, growth failure, and fatigue. The treatment is lifelong gluten-free diet throughout your life. So what are the complications of celiac disease? That's another important issue because that's one of the things we try to prevent through screening. Well, a lot is known about diagnosed symptomatic celiac disease. Less is known about asymptomatic disease, which is what we're likely to detect through screening. So here's a figure from a review paper in Nature Review Gastroenterology Hepatology earlier this year. We tried to outline the mechanisms behind the complications and associations of celiac disease. Of importance here is that the autoimmunity, which is often linked to celiac disease, may actually be due to genetic mechanisms rather than the inflammation. If that is the case, that is one complication we will not be able to influence through the institution of a gluten-free diet. That's something which Yuan et al. In our team showed in the Journal of Autoimmunity last year. We've also looked at the importance of mucosal healing because that is the end result of a gluten-free diet. And the red dots here represent those complications which may be improved through the institution of a gluten-free diet and mucosal healing. So potentially less bone mineral density disorders, less fractures, perhaps less lymphoma, perhaps not so sure about mortality. But the blue dots here signal complications which are less likely to be affected by a gluten-free diet. And the yellow ones signal complications which might actually increase with the start of a gluten-free diet. So what is mass screening? Well, mass screening is about testing asymptomatic individuals, population-wide, and they've started in Italy, and there are some US pilot programs, for instance, the ASK study in Denver. We contrast that with case finding, and I define case finding as a targeted examination of individuals or groups who are suspected of having or at the risk for a disease, in this case, celiac disease. So what about the criteria for screening? What needs to be fulfilled for us to start population-based screening? Well, the WHO has set up a number of criteria, and I think the first ones are quite, clear in celiac disease. They're already fulfilled. So we should focus on the ones I do not think are fulfilled. And this is, for instance, this one. If undiagnosed and untreated, the disease will lead to severe complications. I do not think we have evidence to prove that. Testing and treatment is cost effective. I'll come back to this during my talk because also here I'm not convinced. And this table, by the way, can be found in this paper in the UEG journal that we wrote in 2015. There's an ethical distinction between screening and case finding. Screening is initiated by institutions, not by individuals. There's a higher ethical threshold required for screening, and there's a clear risk of overdiagnosis and overtreatment. In contrast, I see very few ethical problems with case findings. There are, of course, potential benefits of screening. Absolutely. I agree on that. We may have an early detection of celiac disease. We could potentially prevent complications. There could be improved quality of life in some patients. But there are also potential harms from screening. And I want to illustrate this with a 2 by 2 table. The problem here is that the tests for sensitivity and specificity are not perfect, and there will be false positives and false negatives in a mass screening of celiac disease. Positive tests in celiac disease, I'm happy. Positive tests in the healthy, the false positive problem. Negative tests in the health in those with celiac disease, also problem. While negative test in the healthy one is what we want. So what does that lead to? Well, having a false positive test will cause anxiety, unnecessary stigma, unnecessary biopsies, a burden of gluten-free disease, which we should not underestimate, and nutritional concerns for someone who doesn't really need the gluten-free diet. The false negative, on the other hand, is also a problem. It might delay diagnosis. So screening must minimize misclassification, especially since we actually deal with people who at the outset are healthy. And then, of course, we have the costs and the resource allocation from a mass screening. For mass screening to be effective, those who have been detected with the disease must adhere to a gluten-free diet. And at the most, we're talking 80% adherence in those with diagnosed CD, and that's probably those with symptoms especially. I am expecting a lower adherence in those with asymptomatic screen-detected celiac disease. And then the benefits of screen-detected celiac disease will thereby decrease. Because the gluten-free diet is socially and economically burdensome. Just last week, I talked to a journalist who told me that whenever she speaks to someone who has celiac disease, these persons tell her the gluten-free diet is so burdensome. And we're actually asking people to adhere to that despite having no symptoms. And the gluten-free diet is not perfect. There is a risk of nutrition deficiencies, risk of B vitamin deficiency, risk of low fiber intake, and other things in non-fortified gluten-free diet. There's also the issue of informed consent in pediatrics that I struggle with every day, that children who are being screened can actually not provide legal consent. Instead, we're asking parents to do so. And there is a clear risk of coercion if screening is implemented in routine healthcare, especially if the physician argues you should be screened. There's also the issue of equity and access. Screening has to be fair. But we believe the screening uptake varies by socioeconomy and education. So there is a risk of excluding disadvantaged groups. I do not think that the US in this case is completely homogeneous when it comes to poverty and when it comes to socioeconomy and education. There's also a different gluten-free diet affordability and access throughout the US and throughout the world. And the ethical imperative is actually, if we are to screen, screening must be equitably implemented. Can it? So what can we do to decrease the number of people who are screened? Well, we can add genetic screening, HLA typing. But even with HLA typing, you have to do that first screening. And even though you can use DQ2, DQ8 to pre-select at-risk children, that will improve efficiency, yes, but it does raise privacy concerns. Suddenly we have sensitive genetic data on hundreds of thousands of kids. Some of these genetic data could reveal the risk for other autoimmune diseases. Does that trigger anxiety? How does that impact on children, knowing they have an increased risk of other autoimmunity? There's a data privacy and secondary use aspect. Screening generates, as I mentioned, sensitive health and genetic data. There's always a risk of misuse by insurers, by employers, and perhaps by commercial actors. There's a question of repeat screening. Celiac disease can develop later in life. This is from the paper by me and David Bergman in Gut in 2022, when we show when is celiac disease diagnosed in Sweden. You can see, well, very many cases are diagnosed and for sure appear in very early age. But they continue to be new celiac disease cases, most likely. So one-time screening will miss cases. Repeated testing, on the other hand, increases cost and burden, and there's no consensus on optimal frequency. Are we going to test at the age of 2 and 5? Are we going to test at the age of 2 and 15? When is the optimal interval? There's also the potential of overdiagnosis and the consequence of this. We're probably likely to diagnose mild or potential celiac disease. It's very uncertain to what extent that may progress to MASH 2 and MASH 3. It's very uncertain if the treatment of these people is unnecessary. And how will people be affected by a gluten-free diet if they do not have celiac disease? Well, we know some of that. Ben Lebwohl and his team have looked into that and published this paper in the BMJ in 2017, where they show that the gluten-free diet is actually associated with an increased risk of coronary heart disease. There's also the psychological effect of labeling someone who is healthy to you're having celiac disease. That is a trauma. And there's the commercial interest, which might actually drive celiac disease screening, and which I'm worried about. Diagnostic companies in the gluten-free industry. So, do we have potential? Is there a potential for conflict of interest here? What about transparency and regulation, which are needed for researchers and other actors when we make calls on screening? So the alternative may be case finding. Case finding targets those high risk or symptomatic individuals. It's more cost effective. There will be fewer ethical concerns, but we will miss cases. So comparing mass screening and case finding, you could say mass screening has a broad reach, case finding is targeted. Mass screening has a high cost, case finding has a lower cost. Mass screening has, I would say, lower benefits by certainty, but we're sure about the benefits of case finding. Mass screening has higher ethical risks, case finding has lower ethical risks. There's also the stakeholders in celiac disease, and here we really need more transparency. We have the children and families, of course. They're probably, some of them will be pro-screening, some of them will be against. We have healthcare providers, policymakers, commercial entities, but we also have the celiac disease researchers. And I sometimes fear that some researchers may want celiac disease screening because it will prove that celiac disease is an important disease. I call this the Olympic sports bias, by which I mean that when a sport is accepted as an Olympic sport, suddenly people look back and say, oh, this is a very important sport, and suddenly it attracts more funding, more interest. And that will, of course, also be the case with celiac disease if it will be mass screened for. So I think screening is really about, given the available resources, do we do the right thing for the right reasons? So speaking about resources, there's an ethical need for cost effectiveness in screening. Screening programs are costly, and programs include testing, biopsies, follow-up, dietitian support, and there's an opportunity cost as well. What else could have been funded by those money now going to mass screening for celiac disease? So is it cost effective? Well, the earlier evidence is, I would say, not homogeneous. The cost per quality adjusted life years varies widely. This cost depends on assumptions about adherence, quality of life gains, complication risk. Case finding may be more efficient. So if we look at some of these studies, we have the 12-year-old mass screening in Sweden, where they used a lifetime model and said the screening costs were about $40,000 per quality adjusted life year. But the researchers then assumed a very high gluten-free diet, a more appropriate gluten-free diet adherence of 80%, then the cost would be around 50,000. There's also a screening study in Italy where we assumed the gluten-free diet adherence to be 98%, and then the cost would be $49,000 per quality. Of course, it will not be 98%. There's also a much lower cost, much per quality, in a study from the Netherlands. But I want to point out that that study was restricted to cases who had at least one celiac disease-related symptoms. That was not true mass screening. Besides, the cost they put up in that paper, like test for celiac disease, including staff cost of 25 US dollars, is very unlikely in other countries. So I've been trying to model the cost effectiveness in in a US setting. I assumed a 1% prevalence, that we would run a TTG test to begin with, and that if this one was 10 times the upper limit normal, we would run another test and not do a biopsy. I assumed an adherence of a gluten-free diet of 80%, that undiagnosed celiac disease would be associated with anemia, reduced well-being, as well as an increased risk of fracture. And then I just assumed some cost, which I Googled. If we assume that there are 3.6 million births in the US and they're tested twice, and that 80% opt for participating in the screening program, and finally that we have an sensitivity in routine testing anywhere in the US of 93% and specificity 98%, then we will screen 5.76 million kids in the US each year, where true positives 53,000 per year, but also 2% false positives. The total cost of this screening program would amount probably to around $500 million US dollars. So what can we otherwise do with $500 million US dollars per year? Where are some alternative healthcare options. We could run about 20 million fit tests for colorectal cancer. We could close gaps in routine immunizations, buy millions of doses, setting up mobile vaccination clinics, because vaccines have a quality cost of around 5,000 US dollars per quality. We could run influenza vaccinations and vaccinate 15 to 20 million kids per year, enough to cover all non-vaccinated kids in the US. We would reduce mortality, hospitalization, complications. We could set up programs for lead poisoning, screening programs to prevent irreversible neurodevelopmental harm, huge impact on cognitive health. We could run mental health screening in children, look for ADHD, depression, anxiety, and train thousands of school counselors and therapy for hundreds of thousands of kids. Or we could screen all kids in the US for celiac disease. So the take-home message from me is that CD is common and treatable. CD is important. I didn't write more than 300 papers about celiac disease because I consider disease to be trivial. Mass screening raises ethical concerns, however, and the benefits for asymptomatic children are unclear. Case finding remains, in my mind, preferable, and I think ongoing research is essential. I also think it's extremely important that if we screen, we must do it for the right reason. There should be no room for Olympic sports bias. So the research gaps to be filled are these. We need to know more about the national history of asymptomatic celiac disease, about the long-term outcomes of early diagnosis, about the cost effectiveness in a real-world setting, about the psychosocial impact of being diagnosed, both among those with a true diagnosis, among those with a false diagnosis. And with that, I'd like to thank you very much for attending my talk. And do not hesitate to contact me. You have my contact details either on my university webpage, Karolinska Institutet, or on my LinkedIn page. Thank you very much.